Medicos. Good day to all of you. So today I am actually starting with a new region, that is the abdomen, and in today's session I will be discussing in detail about the anterior abdominal wall. And before that, so I will just give a short description about the abdomen itself. So our learning objectives for today will be a brief introduction about the boundaries and the extent of the abdomen. Then followed by that, we will try to actually understand the various planes and regions of the abdomen. Then we will pass on to the anterior abdominal wall, that is, we will be discussing about the various layers, the disposition of the various layers, that is how the muscles are actually present in the anterior abdominal wall, the vessels, fascia and the nerves, all which constitute the anterior abdominal wall. Then one important landmark in the anterior abdominal wall is the umbilicus, with respect to which also we will be throwing some light on the importance of the umbilicus. And then finally we will conclude today's chapter with some applied aspects such as the surgical incisions and the various hernias which can occur through the anterior abdominal wall. And finally I will touch upon the osteology of the lumbar vertebra very briefly. Now, coming to the abdomen. So a simple definition of the abdomen, what can be a most simplest definition is the lower part of the trunk. Okay, so the upper part of the trunk we have the thorax, and the lower part of the trunk we have the abdomen. So the structure which divides the trunk into two halves is your diaphragm. So the part of your body cavity and the body wall together below the diaphragm is actually the abdomen. So superior limit or the superior extent of the abdomen is going to be your diaphragm, and below the inferior limit or the inferior extent is going to be your pelvic lower end of the pelvic cavity. Here it is open, but actually it will be closed by the muscles which is the pelvic diaphragm. Okay. Now this hole, right, starting from the upper end of the thoracic diaphragm to the pelvic diaphragm, the lower end of the pelvic cavity, the whole thing can be actually called as the abdomen. But it is again divided into abdomen proper and the pelvic cavity by the plane of pelvic inlet. So the upper border of bony pelvis, below that you have the pelvic cavity, or it also constitutes the true pelvis. So above that what you see is the abdomen proper. Now this abdomen or the abdominal cavity has got its own boundaries. The superior limit or the boundary which I have told you as the thoracic diaphragm, and below it constitutes the pelvic cavity also enclosed by the pelvic diaphragm. Then anteriorly you have a wall which is called as the anterior abdominal wall. You can also call it as anterolateral wall because these muscles and the fascia and aponeurosis, they form the anterior as well as the lateral part, so anterolateral wall. Okay. Then posteriorly also you have the posterior abdominal wall. Okay, you have the posterior abdominal wall. So inside the cavity mainly consists are lined by a serous membrane which is called as the peritoneal membrane, a double layered serous membrane which is called as the peritoneal membrane. And this peritoneal cavity mainly consists of your gastrointestinal tract, your GI tract, and the organs associated with it, mainly your liver and pancreas and spleen. Also you have, embryologically they are actually derived from a common source. Okay, now whether all these things contains within the pelvic cavity? No, absolutely speaking, or to be precise, not all are present. Some are actually inside or lined by the peritoneum, and some are not lined by the peritoneum. It is very early to discuss or go into the intricacies or the details of the peritoneal reflection, so that we will see as the classes advance. So mainly you remember the peritoneal cavity. Inside the peritoneal cavity mainly you have the gastrointestinal tract. Then your abdominal cavity also lodges your genitourinary system. Okay, so mainly these two systems are present inside the abdomen, and the cavity is the peritoneal cavity. So like your pleural cavity or pleural sac, which is again a double layered serous membrane. So these are all coelomic cavities. The boundaries of the abdomen, as I told you, roof is formed by the diaphragm, floor is formed by the pelvic diaphragm. Here the floor is open, but it will be closed by the muscles which forms the pelvic diaphragm. And anteriorly you have the anterior abdominal wall, and posteriorly you have the posterior abdominal wall. Anterior wall is firm, elastic, and it is musculofacial, made up of muscles, fascia and aponeurosis. Posterior wall is again muscular, but fascia also you have, but in the midline what you have is the vertebra. So naturally a skeletal component is also present in the posterior abdominal wall. Okay, so one side in this diagram you are able to see the anterior wall. Here the anterior wall is removed so that you view the posterior wall. Okay. Now a quick look at the abdominal planes. So planes are nothing but the imaginary lines which are drawn for us to have a better knowledge or understanding of the structures which are present inside the abdominal cavity. So these lines can be transverse lines, that is which are drawn horizontally, or they can be vertical lines. So transverse lines, mainly three are important. One is the transpyloric plane. Okay, the horizontal plane. The first one is the transpyloric plane. The other one is the subcostal plane, and third one is the transtubercular plane. So the transpyloric plane is an imaginary plane which passes along the first lumbar vertebra. Okay, so a line drawn along the lumbar vertebra posteriorly, and anteriorly it will cut across the tip of 9th costal cartilage. The subcostal plane is actually drawn at the level of 3rd lumbar vertebra, and then the next one is the transtubercular plane, which is drawn at the level of 5th lumbar vertebra. There are totally 5 lumbar vertebrae. Okay, so L1 you remember, first lumbar vertebra for the transpyloric plane, then 5th is for the transtubercular plane. In between these two, in the middle at the L3 you have the subcostal plane. Okay, now barring or leaving aside the subcostal plane, we will take into account mainly the transtubercular plane, this one and the lower one, and the transpyloric plane, the upper one, because these two horizontal planes and along with these vertical planes are mainly useful for dividing your abdomen into regions. Okay. So basically, remember at least two planes. One is the transpyloric plane at the level of L1 vertebra. The other one is the transtubercular plane at the level of L5. It is labeled as transtubercular because it passes through the anterior superior iliac spine. Now coming to the vertical planes, it is simply named as the right and left lateral planes. Right and left lateral planes. It is a downward extension of the mid-clavicular line. Okay. So from the mid-clavicular line to the mid-inguinal point. From the mid-clavicular line to the mid-inguinal point. Mid-inguinal point is a point exactly at the midway between the anterior superior iliac spine and your pubic symphysis. I will repeat again. It is the midpoint between the anterior superior iliac spine and the pubic symphysis is the mid-inguinal point, which is different from the midpoint of inguinal ligament. Mid-inguinal point is not the same as the midpoint of inguinal ligament. Midpoint of inguinal ligament I will tell in a later session. So this right and left lateral plane is drawn on right side and the left side from the mid-clavicular line to the mid-inguinal point. Okay. So with these two planes, the vertical planes, okay, and then with these two horizontal planes, that is your transpyloric plane and the transtubercular plane, the abdomen can be subdivided into 9 regions. Okay. So these 1, 2 and these planes are considered as simply the vertical planes. So these 3 planes divide the abdomen into 9 regions. Okay. There is one more vertical plane, is the median plane, that we are not using for classification into the 9 regions. So these are the 9 regions of the abdomen. So above in the midline you have the epigastric, and on the either side you have the right and left hypochondriac. So right and left hypochondriac means it is below the ribs or the costal cartilages. In the middle you have the umbilicus, and on either side you have the right and left lumbar regions because it is present on either side of the lumbar vertebra. In the lower part, in the midline, you have the hypogastric umbilicus. Epi means above the gaster or stomach. This is hypogastric below, and on either side you have the right and left iliac regions. Okay. So these are the 9 regions of the abdomen. Now why actually we have to divide the abdomen into 9 regions is for a better understanding of the underlying structures. So in this diagram again you can see epigastric, mostly what are the structures related to you? Main structure is the stomach, and then part of liver, pancreas, adrenal glands and so on. Right hypochondriac mainly for liver and gallbladder. Left hypochondriac is mainly for the spleen and your starting point of the left flexure or the splenic flexure of the colon. Umbilicus is mainly for the coils of small intestine, and part of the duodenum comes here. Right lumbar is for the ascending colon and for the liver, which also extends into this. So left lumbar is for the descending colon and the left kidney. Right iliac is for the cecum appendix, left iliac is for the sigmoid colon and the descending colon. Hypogastric is for urinary bladder and female reproductive organs. So now you have a fairer idea of which organs falls into which region. So a pain in the epigastric region means it may be a simple muscular pain or a deeper pain which is originating from the liver or mainly from the stomach, ulcers of the stomach, or pancreatitis. It may be an acute pancreatitis, pain in the epigastric. So like that, Right hypochondriac is mainly with the liver and gallbladder, pain in the right hypochondriac. Same way, pain in the right iliac region, it might be due to appendicitis in the right iliac region. Around the umbilicus, usually periumbilical region, mostly the children complain of pain around the periumbilical region, is mainly due to the small intestine, coils of small intestine. It might be due to some worm infestation and so on. Okay, so that is why we divide it into 9 regions. Now, we will little bit just discuss about the transpyloric plane. The transpyloric plane, why it is called? Because it passes around the pylorus of the stomach and it lies at the level of L1, first lumbar vertebra, and crosses the tip of the 9th costal cartilage. Crosses the tip of the 9th costal cartilage. The place where actually it is crossed by the 9th costal cartilage, tip of the 9th costal cartilage, even the vertical planes, they have an intersection here. Okay, so it is at that place, again it is very important for the gallbladder, for the position of the gallbladder. Okay. So the transpyloric plane, many structures, L1, because it is first lumbar vertebra, many structures actually lie along this plane. One is the pylorus of the stomach. Then you have the hilum of both the kidneys. Okay, you have the hilum of the both kidneys. Then you have the origin of superior mesenteric artery, fundus of gallbladder. Even at the lower border of L1, your spinal cord ends inside the vertebral column. So these are some of the very few important structures which are actually lying along the transpyloric plane. So it can be drawn along the L1 vertebra, as I told you, that is midway between your xiphisternal joint and the umbilicus. Xiphisternal joint and the umbilicus, or midway between your suprasternal notch, uppermost border of the sternum, to the symphysis pubis. Midpoint between the suprasternal notch and symphysis pubis will correspond to the transpyloric plane, or midpoint between the xiphisternal joint and the umbilicus. So that is about the transpyloric plane. I have told you why the importance of the transpyloric plane, because of this, some of these important structures which are actually lying across this plane. Now, we will directly move on to the anterior abdominal wall. The anterior abdominal wall is a firm wall, but it is elastic in nature. It is distensible, it is yielding. Okay, so it expands or bulges during so many reasons. One is when your gaster or stomach is full, naturally it has to distend. In case of pregnancy, when the uterus is expanding enormously, then naturally the anterior abdominal wall has to yield. So these are one of the two common things. It is the musculofacial wall, and as I told you, it is distensible, it has to yield and expand. There is no deep fascia. If there is a deep fascia in the anterior abdominal wall, deep fascia are mainly made up of collagen fibers. So these collagen fibers, they are fibrous in nature. They don't allow expansion or distension. So that is why there is no deep fascia or absence of deep fascia in the anterior abdominal wall. So the composition of the anterior abdominal wall is not uniform throughout its, okay, it is not uniform throughout, and it differs above the umbilicus or below the umbilicus. Okay, so the thickness also differs. We will see that in the forthcoming slides. The boundaries of anterior abdominal wall in the front by the costal margin. So it is mainly by the costal margin, the right and the left costal margin, okay, which is mainly formed by the 7th, 8th, 9th and the 10th ribs, but not the 11th and 12th ribs. The 11th and 12th ribs, actually they are floating ribs and they don't come anterior. So it is mainly above by the right and left costal margin formed by the 7th, 8th, 9th and the 10th rib. Inferiorly by the pubic symphysis, pubic crust, pubic tubercle. Okay, symphysis, crust and pubic tubercle. Then you have the fold of groin. Okay, this fold of groin, which you are able to see the junction between your anterior abdominal wall and the upper part of your thigh is the groin region. And then more laterally you have the iliac crust. So that is the inferior limit of the anterior abdominal wall. The extension of the mid-axillary line separates the anterior abdominal wall from the posterior abdominal wall. Okay, the extension of the downward extension of the mid-axillary line serves as a boundary for the anterior and posterior abdominal wall. So these are the boundaries of the anterior abdominal wall. The costal margin above, below it is by the pubic symphysis, pubic crust, fold of groin and the iliac crust. Now, from superficial to deep or from anterior to posterior, the anterior abdominal wall is composed of the skin. The foremost structure what you see is the skin. Deep to the skin you have the superficial fascia. The superficial fascia is again made up of two layers. One is the fatty layer and other one is the deep membranous layer. Again, these two layers are not appreciable at the upper part, only at the lower part of the anterior abdominal wall. Deep to the superficial fascia you have the muscles which are actually disposed in the three layers: external oblique, internal oblique and transverse abdomens. Okay, one below the other or one deeper to the other: external, internal and transverse abdomens. Then deep to these three muscles what you have is the fascia transversalis. It is actually called as the fascia transversalis, which is considered as the deep fascia by some authors. The fascia transversalis. Then deep to the fascia transversalis you see the extra peritoneal tissue and then the parietal peritoneum. So these 8 structures form the anterior abdominal wall layers. But in the midline umbilicus, along the umbilicus you see a white line extending from the xiphisternum to the pubic symphysis, which is called as the linea alba. Linea means line, alba means a white. So a white line it is actually called as the linea alba. Along the linea alba the layers are actually reduced to 6 instead of 8 layers. They are actually reduced to 6 because of fusion of certain structures. We will come to it again after some time. So mainly the anterior abdominal wall is made up of 8 layers. We will see in detail about each layer one by one. Now, the skin of the anterior abdominal wall is thin, hairy skin, more elastic compared to the posterior abdominal wall. It is a very thin skin compared to the posterior abdominal wall. And along the skin you can see some lines. These are actually called as the Langer's lines or cleavage lines. Okay. So deep to this what you see is bundle of collagen fibers. spine threads of collagen fibers, and these lines are actually transversely or horizontally disposed in case of your abdomen, but as you go to the lower lip they are oblique and then vertical. Incisions along the anterior abdominal wall, on the anterior abdominal wall, are actually along these lines because they provide minimal scar. Okay, so once the incision is closed, naturally whatever the wound which is created by the incision leaves minimal scar. So that is why these cleavage lines are actually preferred. Minimal incisional scar along these lines. Okay, so here you are able to see a groove anteriorly overlying the linea alba. Then what is linea albicans? A median groove which is actually overlying the linea alba. Then you also see a lateral curved grooves, that is representing the linea semilunaris on the surface. Linea semilunaris is a laterally curved line with the convexity facing outwards or laterally and represents the lateral border of the rectus abdominis muscle. Okay. So the lateral border of rectus abdominis muscle, abdominal muscle, which is present in the midline. So these muscles are mainly responsible in a well-built, well-developed muscle, and in a well-built person you can see the impressions of these muscles, and which is commonly referred as the six packs. Okay, so that is about the linea albicans and linea semilunaris. Now, in the skin of the anterior abdominal wall, mainly you come across a depression which is actually called as the umbilicus. Okay, the umbilicus serves as a very important landmark. Mainly developmentally it is important, structurally again it is important, and it serves as a plane of cleavage for so many structures. So let us discuss about the umbilicus. So the umbilicus is actually defined as the umbilical scar. It is a depressed tissue which is present, and it is the site of attachment of the fetal end of the umbilical cord. So one end of the umbilical cord is attached to the umbilicus, and other one will be attached to the placenta. The umbilicus is actually present at the intervertebral disc between the L3 and L4. Between the L3 and L4. Again, the position of the umbilicus varies. In children, it is at a lower level because the pelvis has not developed still. It is under the process of development. In older, elderly aged persons, this umbilicus again is at a lower level because the tone of the muscles are lost. Okay, the tone of the muscles are lost, and when there is a laxity of the muscles, naturally what happens is the umbilical level might go down. And again, based on the belly fat and all those things, what happens is the umbilicus level, the position of the umbilicus might vary. Okay, the umbilicus is actually invaginated or a depressed scar tissue, as I told you, but it gets everted. It might evaginate, protrude out or everted in certain cases. One is if the abdominal cavity is filled with fluid. Okay, if there is a fluid in the peritoneal cavity, most commonly in ascites, or In the pregnancy, when actually when the anterior abdominal wall enlarges, expands enormously, then actually what happens is the umbilicus might get evaginated or everted. Now, the importance of the umbilicus, it is the meeting point of the embryonic folds. Okay. A two-dimensional embryo becomes three-dimensional when it gets folded. The two lateral ends. Before the formation of these folds, you call it as a disc. The embryo is in the form of a disc, flat, two-dimensional disc. The two lateral folds and the head fold and the tail fold all meet at the region of umbilicus. And the site of attachment of, as I told you, the umbilical cord, the fetal end of the umbilical cord. Then it is the meeting point of the embryonic fold. Then during the process of your gastrointestinal tract development, herniation of the intestinal loops takes place through the umbilicus. Herniation of intestinal loops, they actually takes place through the umbilicus. But again they return back to the abdominal cavity, which is called as the physiological herniation. Then the umbilicus is a site of portosystemic or portocaval anastomosis. So the veins of the portal vein, branches are tributaries of the portal vein, anastomosis with the tributaries of the caval or the inferior vena caval system. So this is one place where there is a portocaval or portosystemic anastomosis takes place. Then it is common site of herniation, umbilical hernias. Okay. Then the umbilicus is also called as the watershed line. It is called as the watershed line. Whenever we come across the term watershed line, means the lymphatics don't crisscross. Above the umbilicus, it is drained into the axillary lymph nodes. Below the umbilicus, it is actually drained into the inguinal lymph nodes. Now remember, this is mainly for the wall, not the whole abdominal cavity. So it serves as a watershed line, as I told you. Now this skin over the umbilicus is innervated by T10 segment of spinal cord. Now from this T10 segment, the sympathetics innervate the testis in case of males and ovary in case of females. So any pain of the originating from the testis or the ovary must also refer to the umbilicus. So umbilicus referred pain from the testis and the ovary because of the T10, which innervates the skin of the umbilicus, and sympathetics from the T10 supply the testis in case of males and ovary in case of the females. Okay. So there you are able to see the umbilical cord, which is actually attached. These are the umbilical vessels, mainly the vein and the arteries, site of attachment of the umbilical cord. Then some folds are also attached. Okay, and it is also a common site of urinary fistula. So this is your urinary bladder, and to the umbilicus there is an extension which is called as the allantois. This allantois should get obliterated and should be represented by a ligament in the midline. It's called as the median umbilical ligament. If at all the urachus is patent, which means it is active, it is not obliterated, then it might produce fistulas, communication between your umbilicus and the urinary bladder. So that is called as urinary fistula. Then as I told you, again it is a common site of herniation, the umbilical hernias. So coils of intestine might protrude because it is again a weak area in the anterior abdominal wall. So the folds relating to the umbilicus are, one is median umbilical fold or median umbilical ligament covered by the fold. Median umbilical ligament is actually a remnant of the urachus. Then median, this is, then you have the medial umbilical fold, which contains the obliterated umbilical artery. Okay. So umbilical arteries form the medial umbilical ligament. Median is actually the remnant of urachus, which is nothing but your allantois, urachus or allantois. If this is patent only, you get urinary fistulas. So this ligament extends from the umbilicus to your apex of the urinary bladder. Then from here, from the ligamentum teres to the liver, you have the left umbilical vein, which is obliterated as the ligamentum teres hepatis. Okay. So this ligamentum teres hepatis is actually obliteration of this part, the obliterated left umbilical vein, ligamentum teres hepatis. So these are fibrous bands, mainly your median umbilical ligament, which is your urachus, medial umbilical ligaments, which is your obliterated umbilical arteries, then ligamentum teres hepatis, which is your obliterated left umbilical vein. So skin is mainly supplied by lower 5 thoracic nerves, 8, 9, 10, 11, 12. The 12th nerve is actually called as the subcostal nerve, and then by L1 segment through the iliohypogastric and the ilioinguinal nerves. Iliohypogastric and ilioinguinal nerves. These are all actually the ventral branches, cutaneous branches. Thoracic segments, intercostal nerve, same as that, the ventral branches. Okay, they supply the anterior abdominal wall and they also pierce in the midline the rectus sheath. So lower 5 intercostal nerves and iliohypogastric and ilioinguinal nerves, which are from the L1 segment of the spinal cord. So the skin of the umbilicus, so skin of the anterior abdominal wall followed by the superficial fascia, we have actually discussed. Not the superficial fascia, the umbilicus we have discussed. Now moving on to the next layer is the superficial fascia of the anterior abdominal wall. It mainly consists of a superficial fatty layer which is called as the fascia camphor, and then the Scarpa's fascia, which is the deep membranous layer. Now these two, the superficial fascia, can be appreciated as two separate layers only below the midway between the umbilicus and the pubic symphysis. So at this, along this line, midway between the umbilicus and the pubic symphysis. Above this line, these two fascia, that is the camphor and the membranous layer, the Scarpa's fascia, are fused. We cannot separate them. Coming to the fascia camphor, it is subcutaneous and it blends with the fascia of the adjoining region over the skin of the lower limb or the thigh, and it continues subcutaneously into the scrotum as the dartos fascia or the dartos muscle. Okay. So dartos fascia or the dartos muscle, it is subcutaneous and blends with the adjoining region, as I told you. So only in the testis it is replaced by the dartos muscle. That is about the camphor's fascia. The next, coming to the Scarpa fascia, the fascia Scarpa. This fascia Scarpa, it is attached along the fold, inguinal fold or the fold of groin, Holden's line. So it does not cross beyond the or go to the thigh region. Then below and medially it continues as the fascia collis of the perineum, collis fascia, C-O-L-L-E-S. Okay, the fascia Scarpa, actually what happens, continues as fascia collis. Now above the midway between the umbilicus and the pubic symphysis, it fuses with the fascia camphor as the single layer. You cannot separate it above. It fuses with the camphor as a single layer. Below and medially what happens is continues as the fascia collis of perineum and also forms the fundiform ligament of penis. Here it is attached along the Holden spline, so thereby does not enter into the thigh. In the midline, fuses with the linea alba and the pubic symphysis. In the midline, it fuses with the pubic symphysis, and as I told you, it forms the fundiform ligament of penis and the Colles fascia in case of the perineum. So that is about the superficial fascia of the anterior abdominal wall, which is the fascia camphor, and other one is the deep membranous layer is the fascia scarpa. The next is the external oblique muscle. The next layer which we are going to see is the first muscle of the anterior abdominal wall, is the external oblique muscle. The external oblique muscle arises from the lower 8 ribs. It interdigitates with the lower 4 digitations of the serratus anterior and also with the latissimus dorsi muscle, a large muscle which is present on the superficial back region. The fibers, the most posterior fibers, they pass vertically downwards and get inserted into the iliac crest, that to the ventral lip of the iliac crest, into the inner area or inner lip of the ventral segment of the iliac crest. The remaining fibers pass downwards, forwards and medially, and they get inserted in the form of broad aponeurosis. Which is called as the external oblique aponeurosis. Okay. This attachment is in the form of an italic letter F. It is in the form of an italic letter F, the external oblique aponeurosis. In the midline, it attaches to the linea alba, extending from the xiphisternum to the pubic symphysis. Okay. Then into the pubic tubercle and anterior superior iliac spine. So this part from the pubic tubercle to the anterior superior iliac spine, the aponeurosis rolls onto itself and thickens to form the inguinal ligament. Okay. So between the anterior superior iliac spine to the pubic tubercle, the aponeurosis rolls onto itself and it is called as the inguinal ligament. The inguinal ligament, the lateral part is oblique, whereas the medial part is transverse. It is so you have a lateral oblique part and a transverse part. The upper part is actually grooved. The upper surface is grooved, and the lower part gives attachment to the deep fascia of the thigh. So that is why what happens is it is exerting a pull over the inguinal ligament. The midpoint of inguinal ligament is actually from the anterior superior iliac spine to the pubic tubercle. Okay, anterior superior iliac spine to the pubic tubercle, not the pubic symphysis. So that is the difference between the midpoint of inguinal ligament and the mid-inguinal point. We have two modifications, exactly three modifications. One modification is it sends a medial extension which is called as the lacunar ligament to the pecten pubis, and you also have a reflected part of inguinal ligament. Okay. So reflected part of inguinal ligament. So modification of the inguinal ligament is the lacunar ligament, and you have one more is the reflected part. Then you also have pequeneal ligament. Okay. So we will again see that in the inguinal region what is lacunar ligament. So just remember, inguinal ligament is a modification or thickening of the external oblique aponeurosis. Not only that, this aponeurosis they also form or take part in the anterior wall of the rectus sheath. So this is the rectus sheath which you are able to see here. The anterior wall will be formed by the external oblique aponeurosis. The next muscle is the internal oblique aponeurosis. So here you are able to see the internal oblique aponeurosis. The fibers, the muscle fibers of internal oblique aponeurosis are actually at right angles. They are actually right angles to the fibers of external oblique aponeurosis. So they run upwards, forwards and medially. The origin is actually from the intermediate area of the iliac crest and also from the lateral 2/3 of the inguinal ligament. From the lateral 2/3 of the inguinal ligament and also from the intermediate segment of the iliac crest. The inguinal fibers, they run transversely, and some of the fibers they turn actually downwards and backwards. They turn downwards and backwards, and they are actually the arched fibers which is contributing to the roof of the inguinal canal. So the inguinal fibers are arched fibers. They turn downwards and then backwards. The remaining fibers join with the transverse abdominis, the next muscle which is present deeper to the internal oblique, and they form conjoined tendon. Okay. They insert into the lower 6 ribs or lower 4 ribs xiphoid process, pubic crust, through an aponeurosis again to the linea alba. Now, before getting inserted into the linea alba, at the lateral margin of the rectus abdominis, the aponeurosis of the internal oblique splits into an anterior lamina and the posterior lamina. Okay, into anterior lamina and posterior lamina to cover or take part in the formation of the rectus sheath. Okay. So the aponeurosis of the internal oblique splits and passes in front and behind the rectus abdominis muscle. That is one thing, aponeurosis, as I told you. The muscle fibers form arched fibers through which actually what happens is it forms the roof. Some of these muscle fibers, they get detached as the cremasteric muscle, and intervening fascia is the cremasteric fascia, which actually surrounds the spermatic cord. So they are actually present as spermatic cord loops of fibers, which is called as the cremasteric muscle and fascia. These, what happens when contracted, this cremasteric muscle when contracted, they exert a pull over the testis. They actually pull the testis above, near to the superficial inguinal ring. Okay. Superficial inguinal ring is again a deficiency or opening in the external oblique aponeurosis. Okay. So they exert a pull and bring the testis near to the superficial inguinal ring. The cremasteric muscle is supplied by genital branch of genitofemoral nerve, L1 nerve. Genital branch of genitofemoral nerve. Now, if you strike or the medial side of the thigh is stroked with a blunt instrument, then naturally what happens is you can elicit the cremasteric reflex. So immediately you can see the testis moving above in the scrotum. It is due to the contraction or pull of the cremasteric muscle. This is called as cremasteric reflex, which can be very well appreciated in children, and this reflex is elicited to test the integrity of the L1 spinal nerve, whether there is any damage to the spinal cord at the level of L1. You can actually come or arrive at a diagnosis whether the L1 level of spinal cord is intact or not. So that is about the cremasteric muscle and the cremasteric reflex. So you are able to see the internal oblique fibers, which is running upwards, forwards and medially right angles to the fibers of the external oblique aponeurosis. The external oblique and the internal oblique, both the muscles are actually supplied by lower 6 thoracic nerves, and internal oblique in addition is also supplied by the first lumbar nerve. The next muscle deep to the internal oblique is the transverse abdominis muscle. The name itself is transverse, means the fibers are actually transversely oriented. Again, it arises from the inner lip of the ventral segment of iliac crest and also from the lateral part of the inguinal ligament. Okay. So, from the inner lip, ventral segment of iliac crest, from the lateral half of the inguinal ligament, and also from the thoracolumbar fascia. So, thoracolumbar fascia, again I will discuss about that fascia in the posterior abdominal wall. Now it is too early, and without knowing the posterior abdominal wall structures, it is again difficult to understand the thoracolumbar fascia. So, it is inserted into the xiphoid process, linea alba and the pubic crest. The fibers of the transverse abdominis, the inguinal fibers, I told you, again with the internal, they form arched fibers, take part in the arched fibers, and beyond that, the lower part here, along with the fibers of internal oblique, they form the conjoined tendon. The major contribution of conjoined tendon is mainly from the transverse abdominis muscle. The nerve supply is again the lower 6 thoracic nerves and the first lumbar nerve. What are actions of this internal oblique, external oblique and transverse abdominis muscle? Mainly, they compress the anterior abdominal wall and increase the intra-abdominal pressure in acts of mainly vomiting, coughing, sneezing, defecation, micturition. Okay, and definitely in case of parturition in the females, pregnant females. Okay, so increase the intra-abdominal pressure, and they are also expiratory muscles. They move the diaphragm upwards. Next, when these muscles act unilaterally when they act of one side, they bring lateral flexion. When they act contralaterally, internal oblique of one side, the external oblique of one side, they bring rotation of the trunk. When they act bilaterally, they bring the forward bending or flexion of the trunk. When you want to bow forwards, forward bending of the trunk is mainly by the bilateral action. Unilateral, only muscle of one side acts, it brings about lateral bending of your trunk, lateral flexion. Contralateral brings about the rotation of the trunk. So, these are the actions of the anterior abdominal wall muscles. Okay. So, next we will move on to the next layer. What you see here is the fascia transversalis, which is present deep to the transverse abdominis muscle. Okay. So, deeper aspect of the transverse abdominis muscle, what you see is the fascia transversalis. Above, it is continuous with the fascia below the diaphragm, that is with the subdiaphragmatic fascia. Okay, subdiaphragmatic. Posteriorly, it will actually merge with the fascia on the lateral border of kidney, the renal fascia. Okay, so it is continuous with the renal fascia. Then below the umbilicus, it forms a continuous sheet along with the fascia of the opposite side, the transversalis fascia. There is an oval opening in the transversalis fascia, which is actually called as the deep inguinal ring. An oval gap in the transversalis fascia is actually called as the deep inguinal ring. The details of the deep inguinal ring, we will again come to it in the inguinal region while we deal with the inguinal canal. Then above the umbilicus, it is attached to the linea alba. Okay. So, the fascia transversalis is attached to the linea alba. It is something like an endothoracic fascia which we see in the thoracic wall. This is endo-abdominal fascia. Okay. the fascia transversalis. Okay. So it fuses with the renal fascia, as I told you, and the thoracolumbar fascia, above with the subdiaphragmatic fascia. Below it is attached to the pubic crust, inguinal ligament, and the iliac crust. That is the above the fascia transversalis. So here you are able to see the layers of the anterior abdominal wall. External oblique muscle, its aponeurosis. You have an opening in the aponeurosis for the superficial inguinal ring. Thickening of the aponeurosis is the inguinal ligament. Internal oblique and transverse abdominis, they are fusing to form the conjoint tendon. Before that, these arched fibers forms the roof of the inguinal canal. Deep to transverse abdominis, what you see here is the fascia transversalis. You have an opening in the fascia transversalis, that is the deep inguinal ring. Immediately medial to that opening is the inferior epigastric vessel, which you have seen here. Inferior epigastric vessel, which is medial to the opening of the deep inguinal ring. It is related to the inferior epigastric vessels. Okay, so the deep inguinal ring is actually a gap in this fascia, and it also takes part in the anterior wall of the femoral sheath, not the rectus sheath, the femoral sheath, anterior wall. So that is about the fascia transversalis. Then a few points about the extraperitoneal tissue and the parietal peritoneum, fibroareolar tissue. Now, most of the organs are actually extraperitoneal. They are actually extraperitoneal. Okay. So I will discuss about how it is extraperitoneal, because most of the books they give it as intraperitoneal. It is not intraperitoneal. What is present in between the two layers of peritoneum is only the peritoneal fluid, which is only covered by peritoneum on all sides. That we mean it as intraperitoneal. Otherwise, all the organs are actually lying outside these two layers, so they are to be precisely considered as the extraperitoneal. This extraperitoneal tissue is actually traversed by the median umbilical ligament, obliterated umbilical artery formed by the medial umbilical fold, and then the inferior epigastric artery. The inferior epigastric artery. Deep to the extraperitoneal tissue, what you have is the peritoneal folds. Peritoneum, parietal peritoneum, which can be called as the false ligaments. 5 folds below the umbilicus, median umbilical fold, which covers the median umbilical ligament. 2 lateral umbilical folds, medial and 2 lateral. 1 median, 2 medial, which covers the obliterated umbilical artery, and 2 lateral. Okay. Now, between the medial and lateral, you have the medial inguinal fossa, and lateral to the lateral umbilical fold, you have the lateral inguinal fossa. Medial inguinal fossa and the lateral inguinal fossa, through which the herniation, if at all takes place, can be described as medial and lateral direct inguinal hernias. Okay. So just remember, parietal peritoneum, 4 folds can be recognized: 1 medial, a set of medial umbilical folds, and a set of lateral umbilical folds. Now, briefly, I will touch upon the abdominal incisions. Now, what is an incision? An incision is actually an opening created for access into the deeper structures. The incision mainly depends upon the pathology, what type of the pathology it underlies. Then, based on the site of pathology, so where actually the pathology is present, based on that, an incision should give proper exposure or access to the underlying structures. That is one main thing, adequate exposure to the underlying structures. Second thing, an incision should not damage or cut any structures. Okay, it should not create any permanent damage, it should not denerve mainly. Then third thing, on closing the incision, it should produce minimal scar or wound which should heal faster, and the scar actually should be minimal. So the cosmetic importance also has to be taken into account. So based on this, there are certain incisions which are actually recommended. Midline incision. The midline incisions usually is above the umbilicus and below the umbilicus. Okay, supra-umbilical or infra-umbilical, and but not exactly passing through the umbilicus. It should be around the umbilicus, if at all, if you are going to do peri-umbilical region. Midline incisions are actually called as median laparotomy, opening of the peritoneal cavity. So this is most preferred in case of any emergency operative procedures. The next is the paramedian incision. The paramedian incision, what happens to gain into paramedian structures to the left or right side, mainly on the left side for the left kidney, suprarenal gland. Now this paramedian incision is not preferred. Okay. In paramedian incision, what happens? Again, deep to the skin, superficial fascia, the muscles should not be cut, but it should be split. It should be split, especially the rectus abdominal should be split, pushed to one side. And this paramedian incision, what happens is sometimes has the disadvantages of denerving the rectus abdominis muscle. Then you have Kocher's incision, which is along the subcostal. Incision is actually called as the Kocher's incision. Okay. So on the right side mainly on the right side you have the Kocher's incision to gain access to the gallbladder or the liver. Then it can also be extended onto the left subcostal, mainly for any esophageal procedures or for the gastric procedures. If right, left, and then what happens, you have an upward prolongation of the xiphisternum, then it is actually called as the Mercedes-Benz incision. Transverse incisions, you are able to see many transverse incisions. Most commonly is the McBurney incision. Along the McBurney's point, you have two. One is the oblique one, which is called as the gridiron incision. The transverse one is actually called as the lance incision. The lance incision is preferred over the gridiron incision along the McBurney's point. Okay, the oblique one is actually called as the gridiron incision. Then one more transverse incision is the fan steel incision, which you see here. So this is mainly suprapubic region for the gynecological procedures in females, and this incision is also used to approach the prostate in case of the males. Okay. So these are some of the incisions which are discussed here. Next, herniation, abnormal protrusion of the contents. When it takes place, it is actually called as hernias. Different types of hernias you are able to see here. Inguinal hernia, most common in case of the females because the canal is wider. Then femoral hernia, which takes place in the upper part of the thigh. Herniation of contents through the umbilicus is actually called as umbilical hernia. Above the umbilicus, epigastric hernia will be simple herniation of fat contents. Then you have Spagilian hernia. Spagilian hernia is between the linea semilunaris, the lateral border, and the rectus abdominis, lateral border of rectus abdominis muscle. So between these two, you have Spagilian hernia. it will be a very narrow hernial sac. When the hernial sac is narrow, there is more chances of strangulation of the hernia, the loops of the intestine. Okay. Incisional hernias. So any incisions, if it is not sutured properly, or the incision itself is not properly carried out or not repaired properly, it might create a weakness in that area, abdominal wall, and herniation of the contents might take place. That is actually called as the incisional hernias. Then you also have lumbar hernia, okay, along the Petit's triangle, that is actually called as the lumbar hernia. So these are some of the types of the hernias: epigastric, umbilical, inguinal, Spagilian, incisional, and lumbar hernias. Mostly of the anterior abdominal wall hernias which I am speaking. Femoral hernia is actually discussed in the lower limb. So finally, to conclude, I will just give very short description. The body framework of the abdomen is mainly formed posteriorly in the midline by the lumbar vertebra, first 2, 3, 4, 5, first to 5th lumbar vertebra. Then actually it is mainly formed by the lower third of the thoracic cage. Okay, so the last 3 to 4 ribs and the costal margin. Bony framework gives some protection to the abdominal viscera, especially your liver on the right side, spleen on the left side. Costal margin, which is formed by 7th, 8th and 9th rib. These are the lumbar vertebra, and the pelvis is actually supported by the bony pelvis, which is by the hip bone, articulated in front by the pubic symphysis. Behind you have the sacrum and the coccyx, the bony pelvis, which provides the bony framework. Lumbar vertebra, 1st to 5th, large vertebra compared to the cervical or the thoracic, because they are involved in the weight bearing. They form the lower part of your vertebral column, and you see a curvature anteriorly, especially convex anteriorly. This is a secondary curvature, which means not a primary curvature. Secondary curvature which is developed only after the child starts walking and slowly when the weight bearing takes place. Okay. In between this, you have the intervertebral discs, which is also again very thick and forms or contributes to the 1/4 of the length of the lumbar part of the vertebral column. And this is the secondary curvature. Then you see the intervertebral foramens on the sides of the bodies of the vertebra, through which the lumbar segments of the spinal nerves, 1st, 2nd, 3rd, 4th and 5th lumbar nerve emerges to the intervertebral foramen. L1 we all discussed, transpyloric plane. L3 we have discussed, subcostal plane. L5 transtubercular plane. L2, L4 also serves as important landmarks. Formation of internal iliac, union of the 2 common iliac veins also takes place at the level of L4, and so on. So each lumbar vertebra, some events, they serve as landmarks for so many structures in the abdominal cavity. So the term lumbar lumbus is actually the loin region. You know, we tie a loin cloth means tying around your waist. The region is actually the loin region. 5 lumbar vertebra, the first 4 are typical and the 5th one is actually an atypical vertebra. So each typical vertebra has got a body of the vertebra, large reniform kidney shaped body, reniform or kidney shaped body. Posteriorly of the vertebral arch, which is mainly formed by the pedicles. The pedicles you are able to see here. Then these are the lamina which unite to form the spine. The spine is short spinous process and it is also quadrilateral. Spinous process is short and quadrilateral. At the junction of the lamina and the pedicle, what you have is the transverse process, which is projecting laterally. Okay. So the typical features of a typical lumbar vertebra is reniform shaped body, spine is short and quadrilateral. Then you have accessory transverse process and mammillary process. Accessory transverse and mammillary process. The vertebral notch, inferior vertebral notch is actually deeper as compared to the superior vertebral notch. Okay. So at the junction of the pedicle and the lamina, I told you this is the transverse process. At the same junction, you have the superior articular process and the inferior articular process. So massive reniform shaped body, absence of costal facets, which we have seen in the lumbar thoracic vertebrae for the articulation of the ribs. The demi facets, or at least a single facet in the atypical thoracic vertebra. All these are actually absent. No costal facets on the vertebra. And as I told you, presence of the accessory and the mammillary process. Spine is quadrilateral and thick. So the size increases from first to fifth, and fifth typical one is the largest because it bears the brunt of the whole weight of your trunk, limbs, neck, head. And if you look at the anterior part, the length of the anterior part of the body is actually more compared to the posterior part. Then the transverse diameter is again more as compared to the antero-posterior diameter. Okay. The length of the body is greater anteriorly. The shape of the vertebral foramen is triangular, whereas in case of the thoracic vertebra, it is actually circular. So a short pedicle projecting from the body, and then the inferior vertebral notch, as I told you, which is very deep, quadrilateral spine. So here you are able to see the accessory process and the mammillary process. On the posterior inferior part of the transverse process, you see an accessory transverse process, which is the typical feature of the lumbar vertebra. Same way, you also see a mammillary process on the superior articular process. On the posterior border, you see a mammillary. It resembles a mammillary gland, so that is why it is actually called as the mammillary process. Large reniform shaped body, thick quadrilateral spine, foramen is triangular, inferior vertebral notch is deep, presence of accessory transverse process and the mammillary process. These are all the features of the typical lumbar vertebra. Atypical, the transverse process is thick, short, and it is encroaching onto the body. The sides of the body it encroaches. Small spine, which is not quadrilateral at the tip, but it is somewhat round tip. Instead, we have a rounded tip, largest of all the lumbar vertebra. Superior articular facet faces more backwards than facing medially. Okay, it's more of backwards than facing medially. Inferior articular process faces more forwards. It is more of facing front than facing laterally. Then one more point of difference is the distance between the two inferior articular facet is equal or more. Okay, is equal or more than the superior articular facet. The distance between the superior articular. When you actually compare the difference between the two inferior articular facet and the distance between the two superior articular facet, atypical vertebra, this is equal or more. Okay, in case of the atypical lumbar vertebra, largest of all the lumbar vertebra, mainly pointed or rounded tip, not a pointed tip. The spine has got a rounded tip, that is main one. Then the transverse process encroaches onto the body, and the distance between the inferior articular facets is equal or more than the distance between the superior articular facets. So that is in short about the lumbar vertebra. So in today's class, we have discussed about the anterior abdominal wall in detail, and thank you very much for your patient listening.